Try that again. Good morning, everyone. Welcome to Cardiac Sciences Grand Rounds for March 12th. It is my pleasure this morning to be able to introduce one of our own, Dr. Bryan Haar, who is the new director of the Cardiac Catheterization Lab here in Calgary. Today, I guess he's going to give us the State of the Union and talk a little bit about ACS clinical trials at the Libin Cardiovascular Institute. Try not to make it too political. Okay. Thanks, Bryan.
All right. Promise no politics at all. Thanks, Andrew. So I'm just going to give a little update about our clinical trials going on for the ACS patients at the Libin. For those of you that do service, you'll know that I'm often going around, asking for permission to chat with some of your patients about potential studies that we're doing. And so this is a kind of a crucial part, both for our day-to-day practice as well as developing new treatments that include things like medications, devices, as well as strategies for managing our patients. These are my disclosures. Most of them are trial related. So this is a non-comprehensive list of the studies that we're doing right now at the Libin. But I wanted to highlight Complete 2, which is an investigator-led study led out of Canada, as well as two of our industry-sponsored studies, as well as just briefly mention some of our additional studies that we're doing right now. So Complete, everyone's probably heard of by now, is a practice-changing study, again, led by the Canadian team out of McMaster, the PHRI. And so Dr. Shamir Mehta is the overall PI of the study, and he's engaged us in taking part in Complete 2, which we plan on starting in the next couple of weeks here in Calgary. So just to review, the Complete trial had an international impact on practice of managing STEMI patients with multivessel disease. So after the 3-year outcomes of the original Complete trial came out, it changed both the ACC/AHA guidelines as well as the ESC guidelines. So in STEMI patients with multivessel disease, staged PCI became recommended to reduce the risk of death or MI. And then the European guidelines as well, they recommended either during the index PCI or within 45 days for complete revascularization. So just a little bit of a difference in terms of the timing. So the Complete trial, primary outcomes, they had co-primary outcomes. So the first one, which I think is the important outcome, is CV death or new MI. So one of the often weaknesses or criticisms of interventional trials is oftentimes the MACE composite outcome is driven by revascularization, so need for further stents or CABG. Oftentimes in those studies, when you take out, need for further PCI, there is no difference in death or MI. But in the Complete trial, there was a reduction in death or MI. Number needed to treat of 37. And then when you throw in ischemia-driven revascularization, the number needed to treat drops to 13. So fairly dramatic reduction in events. So here you can see all the secondary outcomes: MI, ischemia-driven revascularization, unstable angina, as well as the key primary outcomes. They were all reduced with complete revascularization rather than culprit-only PCI. So one of the challenges with doing angiogram-guided PCI is that the findings are very subjective. So this is a frequent thing that we encounter at heart team rounds, where a patient's case is presented for revascularization, whether it's left main disease or moderate disease in one of the 3 major epicardial arteries. Someone has called a lesion 70%, but then half the people in the room say, I don't think that's significant. And then the other half said, no, that's clearly significant. You have to treat that. And that has a really important bearing in the management of patients. So for example, in the heart team rounds, It'll determine whether someone needs a sternotomy, right, for bypass surgery. And if you open someone's chest and you put a LIDA on the LAD, but the LAD does not have a significant lesion, you've subjected the patient to open heart surgery. You've wasted the LIDA because it's not going to develop. And then later on, you might get something else happen, like when their disease further progresses, you've lost the opportunity to put a LIDA on, or worse yet, you get like an anastomotic lesion from where you've sutured in the graft. And then conversely as well, for things like PCI, you know, for various reasons, interventional cardiologists can have subjective interpretations of how severe it is. Sometimes the interpretations are more objective than others. You know, sometimes it's an easy lesion, so why not just put a stent in it, call it 70 or 80, or it's a more complicated diffuse lesion. I don't want to touch it, so let's just call it a 50 and leave it alone. So there's been a number of studies from things like FAME for FFR, Sweetheart, and Defined Flare looking at IFR that showed that the outcomes for revascularization are better when you use a physiology guided approach. And so what they found in the original complete trials, they took all the images from the core lab. And once you get into that borderline range and using QCA, which is quantitative coronary angiography, where you use a computer to help you measure the degree of stenosis, most of the benefit or all of the benefit was driven by patients with at least a 60% QCA stenosis. So that's the Kaplan-Meier curves on the left. Whereas on QCA, if it's a less than 60% stenosis, a lot of these patients still went for PCI. There was actually no benefit. So it just goes to show us whether we're biased in our interpretations or more likely we're just bad at interpreting coronary stenoses, that you need a more objective measurement using pressure wires to assess degree of coronary stenosis. Another thing that happens in acute coronary syndromes is a lot of these patients have non-obstructive lesions, but also have high-risk features. So, you know, close to 15 years ago, there was a study published in the New England Journal of Medicine called Prospect that defined a feature called TICFA, or thin cap fibroatheroma. That was a predictor of future events in non-culprit coronary arteries. So these are patients that have had a recent destabilizing event in their coronaries, causing an acute coronary syndrome. You treat the culprit lesion, but then elsewhere, these patients will have a future event during both short and long-term follow-up. And oftentimes these aren't 70 or 80 or 90% stenoses. They can be 20, 30, or 40%, but they have features of a thin cap fibroatheroma, which is a very lipid-rich lesion with a very thin fibrotic cap that is prone to rupture and causing another ACS. So these are lesions that you can't really capture by doing a pressure wire or even an angiogram. You need to do further intracoronary imaging to identify these. But about half of patients with a STEMI had a non-culprit lesion that had vulnerable plaque. So there were two recent smaller studies looking at angiography versus physiology-guided non-culprit lesion PCI. So again, these are patients that come in with an MI, they have their culprit lesion, the one that caused the event, treated, and then they also have other moderate to severe lesions elsewhere. So this first study called FRAME MI did show that when you do pressure wire guided PCI for the non-culprit lesion, there's a reduction in events. So that includes death, MI, and repeat revascularization. Conversely, an earlier study called FLOWER MI did not show any difference between doing angiography or FFR guided PCI. But what they did show, depending on how you look at the results, is that you end up deferring about 1/3 of the PCIs that you send for staged PCI. So about 1/3 of patients, both in FLOWER MI, and if we step back to FRAME MI, similarly, 1/3 of patients underwent, or 1/3 of patients ended up having deferred PCI when they've had a pressure wire assessment. So 1/3 of the time we're wrong on assessing the lesion severity. Challenges with these studies, though, is that they're small. The number of primary outcomes is in the 50s for both of them. Frame had to deal with the COVID pandemic. They actually ended the study early because their enrollment rate was half of what they expected because of COVID. So we're still left with the question. This editorial by Dr. Mehta is, how should we approach these patients with for the complete revascularization question? So the complete trial established the benefit of complete revascularization, again, with angiography guided PCI, STEMI patients with multivessel disease. But the question then is, with these newer technologies and better technologies, what's the best way to assess which non-culprit lesions we should revascularize? This is a study. So the original complete trial was 4,000 patients. This one's 5,100. The initial enrollment criteria are similar in that the vessel needs to be of a decent size of at least a 50% stenosis. They are including non-STEMI in the study though, whereas complete only with STEMI. And then the patients are randomized to either angiography guided non-culprit lesion PCI. So that was the superior treatment in the original trial. And they're comparing it to physiology guided non-culprit lesion. We talked about intracoronary imaging, and optical coherence tomography has a resolution that's at least 10 times higher than intravascular ultrasound. So they're using OCT. And so a sub-study there is that we'll be looking for patients with vulnerable plaques, as well as using OCT guided stent optimization, as a number of studies have now shown that intracoronary imaging results in reduced outcomes for patients treated with PCI. In fact, there's a publication in the Lancet that came out this month. That was a meta-analysis that showed a 50% reduction in events when you do IVUS or OCT guided PCI versus angiography. Study is going to go on for about 3.5 years, and the primary outcomes are similar to that of the original complete trial. So the first question in the study is to determine whether physiology-guided PCI is non-inferior to angiography-guided PCI. And then subsequently, is physiology-guided PCI superior to angiography-guided PCI? Yep. Mm-hmm. Yes. Correct. That's a very good question. So Dr. Raj had a question about QCA, or quantitative coronary angiography, which is a system that you can use ad hoc in the cath lab. You do your angiogram and you calibrate it to a guide catheter, and then you draw along the vessel, and then the computer tells you, based on its measurements in that particular view with the angiogram, how severe the stenosis is. So that's what QCA is. And so in the complete trial, both complete and complete 2, it's actually the subjective interpretation of the interventional cardiologist. So if I say it's 70, then it says it's 70. But then to take out the error that is introduced or the bias of the interventional cardiologist, you end up using a pressure wire in the intervention arm of the study. Whereas the control arm, which is angiography guided PCI, still has that bias from the intervention. These are our inclusion criteria. The timelines are tight, so they have to be within 3 days of their index revascularization. And they have to have multivessel disease. So you separate out into the 3 major coronary territories. Ramus counts as a circumflex, and they have to be deemed amenable to PCI. They have to have at least a 50% stenosis and at least a 2.5 millimeter diameter. And originally, the strategy has to be for complete revascularization. These are the exclusion criteria. So if we're going to send them for CABG, they're not going to be eligible. If you can't tell what the culprit lesion is, they're not eligible. If the culprit lesion is undeniably very tight. So visually, most of the studies say that once you get 90% or above in the severity, there's not much of a point of pressure wiring that because it's kind of hard to fudge a 90% stenosis. And also if there's reduced coronary flow, so that's when you inject the dye into the coronaries and you see the dye slowly trickle through. Those patients are excluded because there's no point of doing a pressure wire on those. We do allow chronic total occlusion PCIs as long as it's not the qualifying non-culprit lesion that you're randomizing within the study. So again, these are the primary outcomes that I mentioned earlier for efficacy and safety. Secondary outcomes include the components of the composite outcome. And so what cutoffs do we use? So there's a measurement that's called RFR. So there's all these funny acronyms that Dr. Raj had kind of mentioned in interventional cardiology, and we like to use as many acronyms as possible. So RFR is just the IFR equivalent developed by Abbott. So IFR is the resting index that has the best data in randomized control trials, but the IFR is patented by Philips. So that's led all the other pressure wire makers to kind of develop their own equivalent. So Abbott uses RFR, and Abbott did provide quite a bit of the funding to PHRI to do the study. And then for what it's worth, DPR is what we tend to use a lot of in Calgary, which is made by OpSense. And then FFR is not patented, so all the manufacturers will use FFR. But these are using the typical cutoffs. So whether it's RFR, DPR, or IFR, the threshold for revascularization is 0.89 or lower. And then for FFR, it's 0.8 or lower for revascularization. And so using pretty standard approaches, and which I won't get into all the nitty-gritty details of all the adenosine, et cetera, but standard approach doing pressure wires on these lesions. So this is the physiology guided strategy. So whether you use the resting index or the hyperemic index with FFR, you can see the thresholds for revascularization. And then as well, we talked about imaging. So there is an OCT sub-study. And so, as we mentioned earlier, there's a subset of patients that will have a high-risk lesion in the non-culprit vessel. There's a number of different characteristics that have been reported in the literature, whether it's the fibrous cap that is thin, if there's discontinuity, this, or lipid arc. And they need to have at least 2 non-culprit vessels that you can do OCT on, excluding them because you need to use extra contrast dye for OCT if they have a low GFR. So that's a summary of the complete trial. So I'll be approaching your patients up in the CCU and on the ward after they have a STEMI or non-STEMI if they have multi-vessel disease. Consideration of the study, and your support is of course appreciated, in particular because this is an investigator-led trial, which will be important for future care. So next off, we're going to talk a bit about one of our industry partner trials, SOS AMI. So the study we've been enrolling in for just over a year now, and it's looking at high-risk patients that come in with an acute MI. So, despite all the different interventions we have, whether it's ensuring patients have complete revascularization, all the latest and greatest in antiplatelet therapy, lipid-lowering therapies, et cetera, there's still a substantial number of patients that will die after having an acute MI. So another challenge is a lot of these patients don't get care right away, whether it's because of patient deciding to delay calling 911 or geographic location. They're just too far from a major center. And so this is looking at a new P2Y12 inhibitor that is given only at the time of an MI or suspected MI, and it's patient self-administered. So similar to how patients with allergies will self-administer an EpiPen, or good old-fashioned nitroglycerin when our CAD patients have chest pain. This is the treatment that's given if a patient is concerned that they might be having an MI. So here, at the beginning of a MI, you get a platelet-rich thrombus, or the white thrombus that we see in the cath lab. As time goes on, you get more mixed thrombus, and you get the fibrin cross-linking, and you get more fibrin-rich thrombus. And then, later on, things like TNK are less likely to work after 6 hours of ischemia. And then even in the cath lab, the wires behave differently if someone's been infarcting for at least 6 hours. The clot is much more organized. It's harder to cross the lesion. You also have more infarction and muscle injury from prolonged ischemia. So the idea in the study with the Soletigrel is to intervene early to treat this kind of platelet-rich thrombus early on, and in contrast to delaying until they finally get to EMS or to the hospital to get treatment with other agents, with ticagrelor, or it's coming to Canada soon as cangrelor through the IV. So Soletigrel, it's a rapidly absorbed and rapidly acting antiplatelet agent. It's also fully reversible, and it goes away quickly as well. So in the phase 2 trials, they found that this 16 milligram dosage was the best. On the right-hand side, you see their peak of onset, 15 minutes to half an hour, and then it goes away after about 24 hours. Get very good platelet inhibition from the medication. The side effects are fairly minimal. So, similar to ticagrelor, a small proportion of patients will get shortness of breath that's transient after self-injecting with the Soletigrel. And then the major bleeding events were similar to placebo in these limited numbers, which is not surprising because the medication, again, is fully reversible and it goes away within 24 hours. So this phase 3 study is going on worldwide, taking part in 10 Canadian sites, so we're one of them. So what happens is a patient will get an onset of symptoms. There's an extensive education program that our nurses do with the patient. And so they're taught to recognize symptoms of an MI more so than our usual kind of patient care on the ward. They're given their nitroglycerin. If they're still having chest pain after the nitro, they call 911, and then they self-inject the study drug, and they let us know that they've done so. All right. Okay, got the order wrong. Manon does that education on my behalf in the study. Okay. And so it's a nice little pen. So it's, again, very similar to an EpiPen. We have a dummy injector with no needle that I can show the patients as well. And it's very easy. Just pop the cap off, press the top, and it automatically injects. It's portable. They get 2 of these to go home with. And if one of them gets lost or damaged, we send them a replacement. It's just a really nice device to use. So the primary objective of the study is to treat these patients that have symptoms suggestive of an acute MI, and to try to reduce their chances of having a recurrent MI, or if they do have an MI, because if you intervene sooner, that they'll have a smaller infarction as a result. We enroll the patients within 4 weeks of their MI. We do fairly frequent follow-up with them, mostly on the phone or telehealth. And otherwise, the study is pretty easy to take part in. There's only one in-person visit at the very beginning of the study and one at the very end. So a lot of patients where they're living out of town, for example, they're in smaller centers, the study works well for them, both for the follow-up and as well as having potential access to the medication at an earlier time for treatment. There are outcomes. Primary outcome, we're trying to reduce death, MI with complications, STEMI, high risk non-STEMI, larger non-STEMI. Also looking for bleeding. So again, they have to be within 4 weeks of randomization. We also have the patient try doing a placebo self-injection to make sure that they can handle the device. If they're at a high risk of bleeding, we don't include them in the study. And then these are our inclusion criteria. So they have to have multi-vessel disease, and then they have to have at least 2 of the following. A second prior MI, diabetes, chronic kidney disease, PAD, or they were not revascularized during the index AMI. So if you guys are thinking, well, how do you juggle this with complete 2 enrollment? So the complete true 2 enrollment criteria is a lot easier to get in. And these are patients in general with more advanced cardiovascular disease. And you have at least 2 of these enriching criteria. So there's actually surprisingly not that many patients that we have that fully meet all of these criteria. So these patients are much harder to come by than the complete 2 patients. They are allowed to be on a P2Y12 inhibitor. In fact, they can be even on a NOAC or DOAC, such as apixaban or rivaroxaban, as long as they're not on triple therapy. So recognizing that there are some challenges, so it's an innovative concept in treating cardiovascular disease. So you have to treat before you get the diagnosis of an MI. So the sample size is powered such that, proportion of patients that inject are actually false positives, or actually not having an MI. It does require the patient to reliably self-inject as well. So some patients, you might run the risk that they either forget or they're not confident in doing the self-injection. And it requires frequent training and retraining of the patient to ensure that help with that. It's also hard to do because you have to collect a number of troponin values up to peak in the non-STEMI patients. And then there are some technical things, whether they're on clopidogrel or ticagrelor, in terms of how we dose it right after they inject. The SOS AMI study. So for the electrophysiology folks, the name of the study might sound familiar because they are doing a similar study with this medication for, I believe, for treating AFib. We're doing the ACS equivalent though. It's called the Brexia ACS. So this is a phase 3 RCT looking at milvexian, which is an oral factor 11A inhibitor, which is a new class of antithrombotic therapy. And it's used for treating patients after a recent acute coronary syndrome. So one of the challenges with patients that have an ACS is that they can have recurrent ischemic events, and oftentimes those are thrombotic events. And so we do have dual antiplatelet therapy, whether it's aspirin, ticagrelor, aspirin, clopidogrel. And then there was that ATLAS trial that came out 10 years ago or so that showed that you can give rivaroxaban 2.5 immediately after an ACS as well, so like a modified triple therapy, but the bleeding risk was higher in those patients, but they did have a reduction in MACE. We took part in the Canadian-led COMPASS trial that looked at treating chronic CAD in patients that are not on DAPT. So that's aspirin plus rivaroxaban 2.5. But the usage is very low, and there's still a risk of increased bleeding with it. And so there is an unmet need, whether it's AFib or ACS patients, where patients could benefit from being on anticoagulation. However, the challenge with all the other meds that we've had so far, factor 10As, antiplatelet therapies, P2Y12 inhibitors, is that there's always a balance, right? You reduce your chances of having a thrombotic event, but you increase the risk of bleeding. So the hypothesis in this study is that treatment with the factor 11A inhibitor milvexian, in addition to antiplatelet therapy, will be superior in reducing MACE when compared to standard of care, and it needs to be started within 7 days of an coronary syndrome. Similar to most ACS trials, that's our composite MACE, cardiovascular death, MI, and ischemic stroke. And this is like the crux of the study, is the safety. So let's assess the risk of bleeding with this medication. And the hope is that there will not be an increased risk of major bleeding with factor 11A inhibitors. So if you kind of reach back to medical school, like there's the hemophilia A, hemophilia B, where patients have factor deficiencies that are at increased risk of life-threatening bleeding. There's also something that some people will call hemophilia C, which a lot of people genetically have, might not even realize it, really have a defective or reduced amount of factor 11A. And so what's interesting is those patients over a lifetime, they're less likely to have a stroke or an MI, and at most they have an increased risk of kind of more minor bleeding. So, bleeding after cuts or bruises, but no major bleeding. So the hope is that if you can replicate that in your patients, that you can safely reduce their risk of having a major adverse cardiac event without increasing the risk of a major bleed. This is a study design. So, in comparison to the SOS AMI patients, a little bit more involved. We have visits every 3 months. So, if we talk about how we prioritize which patients go into which study. So again, these are patients that have additional risk factors compared to things like the Complete 2 trial. And so geographically, it's going to be easier to enroll somebody that lives near Calgary than someone that's 3 hours away in a different city. Patients are also stratified based upon their antiplatelet therapies. And so it's a big international study. We're enrolling 16,000 patients. They're expecting about 6% of patients to have the primary outcome. And there will be an interim analysis to look for futility. So these are inclusion criteria. So we are enrolling all types of ACS, so that includes unstable angina. And these kind of enriching inclusion criteria are a bit easier to hit than in the SOS AMI for them. And so as such, we can get more of these patients in. Our exclusion criteria is obviously if it's not a type 1 MI, we're not enrolling them study. These patients also have to have all of their revascularization done before being randomized in the study. So that does cause us to have some tight timelines, and we do miss some patients as a result while they're waiting for their stage PCI or waiting for CABG for complete revascularization. In this study as well, you cannot have patients receive chronic anticoagulation with things like warfarin or apixaban, whereas in the SOS AMI study, we could. And so the study intervention, we try to get the patients in as soon as possible to their randomization and within that 7-day time window. And again, the end of the study will be reached when we reach patients that have at least one event. That's the Librexia ACS study. So that was like a non-comprehensive list of studies, but opted to focus on the 3 that we're actively enrolling or will be enrolling soon most heavily on. Just a friendly reminder, I talked about the reverse study at the last grand rounds. It's a ticagrelor reversal agent. It's still ongoing, but the arm of the study that's ongoing is the patients that have a major bleed on ticagrelor. So if you're on consults or on CCU, they have a patient that has a major bleed on ticagrelor, they're eligible to be in this reverse study that we're doing with Alex Gregory. We're also doing an anterior MI study. We've had a couple patients enrolled in the past month as well. This is a medication that's aimed to reduce oxidative injury, to reduce infarct size, prevent death and heart failure in the big anterior MIs. As well, we're still doing the HARP study, which is a MINOCA study. So the first study for that we published in Circulation a few years ago, and now we're doing a larger HARP study. So if you have any patients that you diagnose with MINOCA or myocardial infarction with non-obstructive coronary artery disease, let me know about that. And then perhaps at another grand rounds, when we start the STEMI DTU study and another study that is another phase 2 STEMI study, we'll chat more about that. Wanted to thank my research team, Debbie Eichmann, Linda Manastersky, Milada Pajovic, and Manon Topping, as well as our interventional fellows who help a lot with our studies.
So we will throw it open to questions, both online. I'll open the chat if people want to type questions, or you can just speak up. And I'll ask the room if there's any questions. It's a practical question. If you are, let's say, investors, FFR or RFR, how does that interrupt the flow of the capital? How much extra time does that take?
Yeah. So, the question is how much extra time does it take to do a pressure wire? The nice thing is that it's all integrated into our cath lab system. So the OpSense we've kind of rigged into the systems. That's our most commonly used pressure wire. So, realistically, to put up a guide and send a wire down, it's probably 10, at most 15 minutes. As long as the lesion isn't too hard to cross. Sometimes you have a tortuous vessel, it takes time. And especially using the resting indices, so things like RFR, IFR, DPR, you don't need to mix up adenosine, you don't give adenosine. So it actually makes the procedure even faster. It's even money saving as well, because adenosine is quite expensive. So it actually doesn't add that much time. Yeah. So, and unfortunately, it's something that, in a lot of cath labs, it's a bit underutilized and it should be done more often. The guidelines recommend it, but it's still a thing that's common topics, similar to not doing enough intracoronary imaging, that is a limitation in a lot of cath labs.
Follow-up question to that. So I don't know if you know Jonathan Leipzig from Vancouver. He's been a couple times. He's a big proponent of heart flow, which is have any exposure to that or any comments on perhaps using that?
Yeah, I've definitely have heard of heart flow, and I've seen a couple of talks, but to be honest, we don't have the technology here in Calgary. So my understanding of it isn't very good. But certainly especially recently, there's been a number of publications on CT, CT derived FFR. And the data is pretty good, but yeah, we don't have it here, and it's also not in the current guidelines as well.
Yes.
Right, that's a nice summary. But two questions. They're kind of general, but maybe related to the first. Now, the first one's building on, I guess, Andrew's comment. A lot of the technologies, like looking at measurements and other interprocedural imaging, why are they underutilized? Because when we were fellows, some of this technology existed. So it's surprising that years later we're still having the same kind of.
So Dr. Kuryachan's question is, why are some of these technologies underutilized, whether it's pressure wires or intracoronary imaging? And we know that these things improve patient outcomes. And so there's multiple levels. Some of it's more at a systemic level. Some of it's more, at an individual operator level. So if we kind of start big, in a lot of places, remuneration is an issue. So a lot of places you do a pressure wire, there's no fee code if you're a fee for service physician. And then also, whether it's provincial or state level, the government or the insurance provider might not provide reimbursement for the pressure wires themselves. And, a pressure wire can cost $800 to $900 each. Same with each imaging catheter. So if your lab isn't paid for that piece of equipment, then they're less likely to be supportive of it. And then conversely, where that's changing is in Ontario, that they're rolling in imaging and pressure wire into the pay model for the hospitals now. And because there's been so many studies showing that imaging improves outcomes, so there's some states now, for example, Michigan, where they're mandating the interventional cardiologists have a minimum percentage volume of their PCIs that are guided by IBIS. So that leads to our next thing is, operator comfort. So intracoronary imaging in particular, there's actually a lot of interventional cardiologists that are not comfortable reading an IBIS or an OCT image. And so whether it's lack of training, lack of exposure, but there's a lot of people that actually can't interpret it properly. So they choose not to do it. And part of it is also some people are overconfident. They say, I'm pretty sure that's a 3.5 millimeter vessel. But then when you bring it to like 3 other operators, some will say it's 2.5, some will say it's 4.5. And it's the same problem with angiographic stenosis. It's completely subjective and with a lot of inter-observer variability. So, part of it is, some of the docs don't know how to use it. And then finally, Dr. Howarth mentioned, how long does this actually take? And so certainly as you use it more, the faster you get. But, in particular, things like OCT and IBIS, if you're in the learning stages of it, both in terms of learning the equipment, how to operate it, if your techs aren't comfortable using it, or, some of your techs are better at it than others. And also interpreting the images, like once you do enough of them, interpreting them is very quick, right? It's like reading ECGs. When we're medical students, we take forever reading a 12 lead, right? Whereas as an attending, you look at it, you already know what it is right away if there's nothing super complex on it, right? So it's the same thing with imaging and pressure wire. The more you do, the faster you get at it, but it's a barrier, right? If you're just starting off doing it and it takes you like half an hour to set up your OCT, you're less likely to do it.
They're just sort of really, what's the current thoughts on like staging versus doing it at the time?
It's not clear. I mean, so there's a lot of debate about it. So there have been some studies, both randomized and observational, where you do everything all at once, that show that it's beneficial compared to culprit only. But there's also been a number of studies. So like, for example, New York had a big registry and they showed that the outcomes when you do multi-vessel PCI at the time of the MI is associated with worse outcomes. That kind of makes sense, right? Because the patient is less stable, you get more vasoconstriction in the artery, you're less likely to size your stent properly. If you have a complication, now you have an infarct in two territories. So that was one of the comments I didn't get into for the frame and the flower studies. One of them had a lot more PCI at the time of the MI, and a lot of the adverse outcomes were driven by MI and death around the time of the MI done at the PCI done at the time of MI. So it's debatable. And so that's why as well, if you look at the guidelines, the American guidelines say to stage, but the Europeans, where they've had a few more studies done in Europe showing that multi-vessel PCI is safe during STEMI, their guidelines actually say you can do it during the STEMI. So that's actually one disconnect between the two recommendations. So that's a question that I don't think has been fully answered. Dr. Raj.
I missed the tail end of your P2I muscular thing. So question is a question comment, right? One is, so they're jabbing the muscle before you're going to give lots of anticoagulants and maybe.
Yeah, potentially. And so, in the phase 2 studies, there's definitely some injection site hematomas, but then again, small numbers, but the incidence of major bleeds was no different between the different doses of Solidagrel and placebo.
Okay, and what's the event rate that you're expecting in this group, right? You're basically a lot easier if you know someone's having an infarct to power a study than find those that possibly could maybe one day. You're picking an enriched group because they've had an event, but what's the expected event rate and how many people are you guys trying to enroll worldwide?
Yeah, that's a very good question. And we actually encountered that issue in the study. So it's enrolling 14,000 patients worldwide. And the event rates in these patients are going to be around 5 to 6%. With the enriched criteria, which they actually had to revise the protocol. So originally the enriching criteria didn't have as many high-risk patients, and then they did an analysis because their event rate was lower than expected. So they actually increased the number of criteria you need to get, and that's why it's so much harder to get into the study now. But with revised criteria, they're expecting 1 in 4 patients will end up injecting. And then even among those 1 in 4 that actually inject, there'll be, of course, ones that will have false positives, right? They have chest pain that's non-cardiac. And so the idea in the study is that it's still, in terms of bleeding and all that, it's still safe to inject, but you hope that the patients that do infarct will benefit from it. So that certainly is one of the challenges that they've highlighted in the study.
The final thing is a comment, and it's probably not feasible because this isn't your study. This is the study that came down from someone far, far away with lots of money.
Switzerland, yes.
But, there's actually an opportunity in Alberta anyway to do the study better, right? So, I appreciate your graph of all the delays, right? But actually, I think the paramedic delays have been unfair in most cases because that's actually a function of when someone realizes they're infarcting. And the bottom line is they have to realize they're infarcting, or at least think they're infarcting, to jab themselves anyway. So that delay is built in no matter what you do. Right? So the paramedics, way to power this study, push the population, is actually to have the paramedics do this. Right, not wait to get to hospital, not wait to get to a hospital that can do angioplasty. Field to do it, would that add a bit of delay? A little bit. The problem is that in the US environment, paramedics are competing with each other, not a centralized system. And even in Ontario, having tried once to do a paramedic-based study, there are different regions and they don't actually. But there are jurisdictions, and Alberta is fairly centralized and fairly good at this when the paramedics aren't convinced. Managers are trying to get them all fired. There's a morale problem, but you can actually do this study, I think, with a lot less people to try and see if it works. That would actually make a difference. I don't know if you want to propose this as a smaller study. You could probably get it done before there are 14,000 people.
That's a good point. You know, certainly we do have that unique ability in Alberta, and I'm just going to digress a little bit. And so Rob Welsh and Kevin Bainey up in Edmonton have done a similar study called STREAM, where the paramedics will give the fibrinolytic if they diagnose a STEMI in the field. So that's actually now become part of the practice in Northern Alberta, and it's actually now potentially being set up in Southern Alberta as well. So that's that way, this is on everyone's radar now, because they're potentially going to be giving TNK in the field now. So similar concept to what you've suggested there, Satish. Question online. Are there any correlations between Librexia, ACS, stroke, and AFib? So yeah, there's I believe a Librexia AFib study going on right now, and I think there might be a Librexia stroke study as well. But I'm not sure. I can't remember who I know the AFib one is definitely going on here. Is it Urgo that's the PI? Yeah. So I'd have to chat with him because I don't know all the details of that Librexia study. But yeah, it's definitely a big multi-study undertaking right now. Great.
If there's no further questions, we'll close. Thank you very much. That's very interesting.
Thank you.